The views and opinions of this podcast do not reflect the views and opinions of the United States government, the Department of the Interior, the Department of Defense, the Department of Agriculture, the United States Forest Service, the Bureau of Land Management, National Park Service, the Bureau of Indian Affairs, or any private, municipal, county, or state firefighting organization, any law enforcement agency, any medical provider, or any contractor employed by any federal agency. What's up, guys? Welcome back. Welcome back to another episode of the Anchor Point Podcast, episode number 6. Just want to say thank you guys for spreading the word, posting, tagging us in all the social media outlets. Really appreciate it, guys. Keep doing what you're doing. Also, if you guys got time, make sure to swing by old iTunes and drop us a rating. Definitely be appreciated. Today on the show, I got Michelle Raponi. She's actually a really close friend of mine. We started fighting fire together back in, I started in 2009. She started in 2010. And she moved out of the Wildland realm and decided to take on a different little mission. So now she is a fireline paramedic, and she's all over the West Coast fighting fire, helping us fight fire, patching up our boo-boos and stuff like that. Anyways, there's some good shit on the episode here. Definitely sit down and pay attention and listen, because some of the stuff could save someone's life. Could save your own. Oh yeah, little side note, guys. This is for informational purposes only. Make sure you guys are operating under your medical direction and within the scope of your own practice. If you guys aren't qualified to do some of the things we're about to talk about, then don't do it. You could actually further injury. So, without further ado, Michelle Raponi. Welcome to the Anchor Point. You're ready for this.
Yeah.
Come on.
Take 3.
Take number 9.
Yeah.
What do we do next? Which microphone do I fuck with next?
I know. And let them know this is a re-recording.
Well, if I didn't fuck up the entire episode by not having my entire monitor, my anything turned on, is just like recording to the computer mic.
Yeah.
Probably would have, been a success.
Oh,
but,
well, what are you going to do?
all right, so round 9, 2,
Yeah,
4,
right?
Whatever.
Take 3.
Take 3. All right, guys, welcome to another episode of Anchor Point. Today we're going to talk about a little bit of field medicine. I have my really good friend, Michelle Raponi.
Hi.
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 How are you?
Doing
She's
well.
a paramedic and paramagic.
Totally. Paramagical.
Paramagical.
Yeah.
And she's going to talk about some fireline medicine.
Yeah.
Introduce yourself.
I'm excited. So yeah, like you said, I'm Michelle Raponi. I am a fireline paramedic. I got into fire in 2010. Started off actually working with Brandon.
Oh, God.
That was a lot of fun. And then I decided to go to paramedic school and kind of go that route. I worked the 911 system, and I contracted as a paramedic on the fires, whether that be in camp or out on the line with you guys.
Mm-hmm. So 2010 is when you started, right?
Yeah.
Is it 2009? 2010.
You started 2009.
I started 2009. Yeah, 2010 for you.
Yeah.
Yeah.
Yeah. You got this.
It was pretty fun. I don't know.
And a blast.
So, you've been fighting fire for, how long did you fight fire for? Like 5 years?
No, just like a couple. I did just the year with BLM, and then dabbled with some like volunteer structure and everything. But I always enjoyed when we got the vegetation fires a lot more than the structure calls. So I always just stuck with wildland.
See.
Yeah, and I do miss actually fighting the fires a lot, as much as I like sitting out there and watching you guys work so hard.
Thanks. Yeah, how's that air conditioning?
You guys are doing great.
Yeah, how's that air conditioning treating you?
Oh, it's all right. I don't know. I know. No.
Oh, look at me in my fancy medical unit.
Yeah,
Oh, anyways. So, yeah, let's talk about some medicine. But first, how'd you get in the fire?
Yeah, so as you already know this story, when in 2010 when we were working on that fire together, and I got injured and got mistreated with certain medical, and this was at the hospital that mistreated me, and it made me realize that I didn't want that. Like, I wanted to be out there to help improve and help out with fighting fire. So what happened was we had a little
Little.
I mean, we had,
Nothing fucking little about that fire.
yeah,
Well,
Brandon and I were burning out. This is my first year and definitely a rookie. And there was a good wind shift. And the fire started coming at us, and we're in sagebrush, so and it's very windy.
Yeah.
And it got real hot real quick. All of a sudden we had fire on both sides of us, and it was like, oh crap.
Yeah, that thing jumped the line pretty damn quick, and then
Yeah.
it was going like the right direction to where we could probably like cut the fence and like go catch it.
Yeah.
But we're sitting there, and all I remember is Captain hauling ass through like neck high sagebrush.
Yeah.
Like, get the fuck out of here.
Yeah, it's like, what?
And there's this gigantic flaming front coming behind him. And yeah,
Yeah.
it was pretty gnarly.
So definitely was choke and smoke, heat.
Yeah.
It definitely just hit me bad. Engine pulls up. Brandon pulled me up into it after like coughing on our hands and knees. And then, so what happened that evening while we were debriefing, I started not being able to breathe. Skin was red, flushed. I was kind of getting wheezy. And if you're not familiar with airway burns, they're not a good thing. And we didn't know if I had airway burn, was I just having a reaction to the smoke. Either way, we decided to go into the local community hospital, and they x-rayed me to make sure I wasn't swelling. There was like minor swelling in my larynx, which is what they want to monitor. My O2 stats were in the low 90s, which isn't bad. So they just put me on.
Not bad, not great. Though.
No, it was like 90, 92%. And so they monitored me, kept me on oxygen overnight, and it just wasn't getting better. And the thing with airway burns is it can take 24 to 48 hours for your throat to swell up. So the next morning they x-rayed again, and there was more swelling. So they made the call to intubate me and like fly me out to a trauma center.
Yeah.
Where they can properly deal with it. And I kind of wish I had the medical experience I do now, because I would have stuck up for myself. I couldn't really talk, as you can imagine. But what happened is when they went to intubate me, normally you get sedated, and then they do have to paralyze you, so they can put the tube down your throat. Well, they didn't sedate me, they just paralyzed me. So that was the part.
Oh, fun.
Yeah. So could you imagine just being chemically paralyzed and everyone thinks you're out? So they intubated me. I remember the helicopter ride. My eyes were taped shut. I couldn't move. My tongue was trapped between the intubation tube and my teeth. I just remember that. I remember trying just to move my toe, and I hadn't even seen Kill Bill at this time. So, because I was just like, that's what Kill Bill. I was like, oh.
Hold on a second. I love how you're referencing a Tarantino flick right now, and this is like actual real life shit that happened to you where you're fucked up, man.
Oh, yeah. So I get to the trauma center, and it is fortunate, but they stuck a camera down the tube. I could feel them. They put a catheter in me, which is, right up your genitals. Felt that. I felt them put it down into my nose. I'm sorry. And yeah, it was really traumatic because everyone also thought I was out.
Did you hear everything?
Uh-huh.
You heard everything.
They took the tape off my eyes so I could see everything. Everyone standing around me, and I'm like awake, but they thought I was out.
Holy shit.
Yeah, and then it was my dad that actually was like, something doesn't feel right, because the paralytic was wearing off, so I was able to kind of start shaking a little bit. Mm-hmm. They're like, oh, no, that's the anesthesia wearing off. And then I was finally like handed a pen. I was like, sedate me. Like, we still have that. Because, of course, as you can imagine, there's a lot of stuff that happened after this incident that I'm not going to go into. Yeah, so that hospital reacted right. They kept me a couple days in the ICU. And, yeah, after that, I was like, I want to get in on the medical side of this. Now, no one on the fire messed up with it, and I think it did happen for a reason, because I'm happy in the path I went.
Yeah.
So
make sure this shit never happens to anybody that you work on.
Yeah, when I became a medic, and we one of the states I work in, they do have RSI, and just talking really make sure that your patient's sedated.
Okay, so for the people that don't know what RSI is, explain
rapid sequence intubation. Of course, I'm just going to use the medical jargon I always do. I'll work on that. So rapid sequence intubation is what we use in the field. A lot of states we're not allowed to use that. So it's where you sedate, paralyze, and then intubate.
Just kind of depends on your state licensures?
Yeah, exactly.
Okay. That makes sense.
Yeah.
Yeah, man, that fire was pretty fucking intense, especially being a second year firefighter. I had
I'm just a rookie.
No fucking clue.
What's happening?
Whoa, look, that's hot.
I know, what?
And this is the hard lesson. That fire actually was a hard lesson that I learned about wearing metal sunglasses, because I had a perfect first degree burn around where my sunglasses were.
Did you really?
Oh, fuck yeah, dude.
Oh, rookie.
Yeah, dude.
How embarrassing.
It was pretty impressive. I've never seen fire behavior like that.
That must have been pretty traumatic for you.
No, not really.
I know, I'm just kidding.
I just look like an asshole.
Totally.
I am an asshole, but whatever.
Yeah.
But yeah, man, That was intense.
Yeah. It was really
Especially that
intense.
young in my fire crew. But that was like one of those things where like, oh yeah, guess what? Fire is real.
What an amazing lesson. I mean, it would have been cool not to have the whole innovation part. And like I said, I would have stuck up for myself, and because I didn't need to be innovated. Yeah, that's the other part. Like,
They just like panicked and made like a panic decision.
and it was a small, local, tiny hospital, and yeah, they made the call to send me to a higher level of care that could take care of me, because and airway burns can be very scary though too.
Oh yeah.
Because if you swell up too much, you're kind of shit out of luck.
Yeah, you got nothing.
Yeah,
No breathing.
Crike, but it's not always gonna work. Yeah. So.
God, that's fucking crazy, man.
Yeah.
All right, let's talk about medicine.
Okay.
Ooh, medicine.
Yeah.
Okay, so where do you want to start?
Oh man, you got to direct me, bro.
I got to direct you.
Like, give me a topic.
Oh, look at this producer and everything. So
I know, it's perfect.
So what are like the most common injuries that you're gonna encounter on the fire line? Like you personally, what like your experience? What have you seen?
So that depends. I'm gonna backtrack a little bit. So for what I do now is as working as a fire line paramedic. My assignments are constantly kind of changing. I'm mostly on the ambulance, sitting on a drop point. That's like a majority. Or I'm working in camp in the med unit trailer. Or I'm on a UTV working with like we have this pretty awesome UTV that we use. So,
doing hot laps.
Yeah, right.
Yeah.
Just donuts around the fire while you guys work. I'm just
Must
kidding.
be nice.
No, absolutely not. So that all kind of depends. So on the fire line, the common injuries we kind of see, we're going to see more minor injuries, of course.
Yeah.
Eye injuries, debris in the eyes. That is a very common one, as you guys can imagine. Poison oak. Yes, that is an injury. I never reacted to poison oak until last year for the first time in my life, and it came out of vengeance.
Ooh.
Yeah, I looked like something out of the lagoon. I'm like, who's going to want me
Creature
now?
from the Black
Yeah,
Lagoon.
just blisters all over my body. I was like, I get it. I know. Because it used to be like, oh, I don't know how that feels, but I feel bad for you. Good luck.
Yeah, poison
Now,
oak.
anyone with oak, I'm like, do you want to come to my support group? Like, I will cry with you.
Let's hold hands.
Yes.
To
Yeah.
get like challenge coins for how many months you've had poison, how many months you haven't had poison oak.
Oh, that should be a thing.
That should be a thing. I definitely think that
Okay,
should
we'll
be.
be talking to someone about that, getting that going. And then, as you can imagine, twisted ankles, minor abrasions, chainsaw. But usually with the chainsaw, it's the dog gets in the tricep. Seems
Dog
like,
in the tricep. I
yeah,
would figure,
because I've had like quite a few of those, which are so easy to fix. Because just that little triangle kind
Just
of. Yep, boop. It's like, I'll fix you.
See, I'm used to like people like tripping and falling with their saw when it's on their shoulder.
Oh,
and
yeah.
it's like stabs them in the neck.
Yeah, and chainsaw injuries are tricky because everything's so ripped up when it does happen with the chain that you can't get stitches. You just get shoved gauze in there and
Ooh, wound packing.
wound packing. And yeah, you
fun.
get sent in for those. Absolutely. So yeah, that's obviously mainly we kind of see more minor. My days tend to be pretty quiet when I'm on the ambulance out there, which is a good thing.
Yeah.
People don't want medical busy. When working in the camp, that's when I'm seeing all you guys, or the ambulance will bring you into just camp instead of the hospital, because that's our goal, to keep everything in-house. Treat you guys, get you back out on the line, and get you the care that is necessary for you.
The down and dirty, the quick and dirty.
Yeah.
Field medicine. All
Yeah,
right.
just some like dirt, chew spit, send you on your way.
Pack the wound full of Copenhagen.
That's like my favorite thing. Packet full of cope.
There you go. So
please don't do that.
let's go into like kind of treatment things, like what to expect as far as like what can like the lay person do as far as treatment for your ouchies, boo-boos, and blisters.
Absolutely.
That kind of shit.
Well, what's been really wonderful is how many EMTs are on the crews, engines, etc. now. And a lot of these EMTs don't actually have experience working as an EMT, but I love it because I'll put you to work. You do, you are familiar.
Yeah.
You just need a little direction. Like,
I need lots of direction. Yeah.
I know you do. But we'll touch on that later.
But yeah, so
with something like a minor, let's say a minor cut on the arm, you guys are, some of you are smart, but you can see like
some of us are. Yeah.
There's a couple of you guys out there, just kidding, but you can tell if you need stitches or whatnot. Having a crew first aid kit, if there's an EMT on the crew, definitely having the kits. And now they have those kits that you can just purchase and throw in your pack, 4 fireline packs, which is wonderful as well. And just address the wound. And then if you think that needs help, like you can call over the ambulance or a medical. There's going to be line medics out there too that are very close by.
Oh yeah.
Another one that we encounter a lot is, as you guys know, bee stings. And those can be scary.
It can be.
Yeah. Luckily, it is nice when someone on the crew does have is allergic and they have an EpiPen.
Yeah.
If someone is allergic, they need to absolutely have an EpiPen.
Well, it sure as shit helps me out if they have an EpiPen on them, because then I can assist them with their medication. But
yeah. So getting the line medics over pretty quick. That's going to be, before the ambulance can get there. And they just are going to treat it with some Benadryl. They don't always need to resort to Epi.
Yeah.
So just if they're having breathing issues, absolutely. If, that person does have an EpiPen, use it.
Yeah.
But it's good to have that kind of Benadryl and whatnot, just being aware that if you are going to give Benadryl, that person can't work anymore because it's going to make you drowsy.
Yeah.
But
the Benadryl will?
Yeah, the Benadryl will. The Epi will do the exact opposite.
Complete opposite.
Yeah, so you're going to be
wound up.
Yeah, if you get Epi, you're going in to be monitored because it's going to speed up your heart right quick. So, yeah.
Can you OD on Epi? Can you OD? I mean, can you literally make someone's fucking heart explode from Epi?
Yeah.
Yeah.
Yeah, I'd say so. And then, ideally, we're not going to deal with this out there, but if someone overdoses from cocaine or codes from a cocaine overdose, if you give them Epi, it'll kill them.
So interesting that you bring up drugs, though,
Mm-hmm.
illicit drugs.
Mm-hmm.
Are you guys protocol to carry Narcan?
Oh, yeah, absolutely.
Yeah. Have you ever had to deal with anything like that on the fire line?
No, not on the fire line.
Oh,
I've been lucky. I mean, I know in camp they've had to deal with that, but that's more of a security issue, and the cops are there, so.
Please stop doing heroin.
Yeah. Oh, being on an assignment and finding a needle in the bathroom. It's like, oh, please be a diabetic.
Dude, oh my God, speaking of needle sticks,
Mm-hmm.
we were doing all of our EMS conference stuff here last week, so it was just 12-hour days of just running scenarios and shit.
Yeah.
Doing cool field medicine, improvised medicine and stuff. And we're dragging this dummy over, one of those big ass Tom dummies, right?
Yeah.
He's got a sucking chest wound and he's all fucked
Beautiful.
up. Yeah, he's
Love
awesome. He was in a vehicle accident or something like that. UTV rolled over. Anyways, we set him down and then we're working on him, waiting for the ambulance to show up, ALS to show up. And once the scenario was over, we start peeling everything off. And dude, there was fucking 3 hypodermic needles just sitting there. I was like, oh God, what the fuck, man? Oh my gosh.
Luckily they probably weren't used.
No, they're...
Oh, that's lovely.
They looked used.
Oh, I see what you're saying.
Yeah.
That's disgusting.
Yeah, it was
but it happens.
fucking disgusting.
Yeah.
So,
I want to look out for those sharps.
Dude, that's, get a fucking needle stick.
Right.
Gross. So, with owies, boobies, and blisters, do people come into the med unit and with the most annoying shit for you? What pisses off the med unit?
Okay, so it actually takes a lot to actually piss me off, but when it's gonna sound really mean, when you're just being a fucking baby, I'm sorry. There are, and on the other end of the spectrum, there's these guys, especially it seems like first years, that don't want to say anything, and before you know it, they're having to go home because the whole bottom of their foot is sloughed off.
They're just hiking on these fucked up boots, and so, fucked up feet.
Yeah, just having your moleskin. Yeah, it's a new
moleskin.
Thing. Yeah, moleskin.
Moleskin.
Yeah, got it. Thank you. Having your moleskin, taking care of your feet is really important out there. When you start to get a hot spot, good old white bite for those of you who know. That's what the med unit is there for, to get those supplies. That's the big part.
Kind of re-up on.
Yeah, and if you are having issues with your feet, people will look at it. A lot of people don't have any kind of medical training, or this is their first kind of job out there, especially the young guys that just needed a job. So
and they don't want to say anything because they're like, oh, I don't want the suit to think I'm a bitch or something like that. And their fucking foot's duct taped together.
Yeah, if someone's kind of being too whiny about it, though, I will definitely just tell them I need to turn it down a notch and get working.
Got any funny stories?
Yeah,
I know you do.
This does not have to do with feet. This is a few years ago, and I was in the med unit trailer. It was actually at night, so we were back from the day, and this guy comes up and he's like, my crew member's choking. And we're like, oh, where is he? He's standing right next to him. He's like, right here. He's like, it's me. It's like,
you're not choking if you're talking to me.
The guy I was working with was like, yeah. He's like, you're not choking if you talk. And he's like, how long has this been stuck in your throat for? He's like, a few days. He's like, and his supervisor, we'll just call him that, his soup, was like, you need to help him right now. He is choking. He can't breathe. And the patient was literally like, yeah, I can breathe. It's in my, like, because it was in his esophagus. And I kid you not, on that fire, we had like 3 guys that got steaks stuck in their esophagus. So it was, you know, kind of putting out a public service announcement to chew your food before swallowing. But I love that stuff. I'm like, why are you freaking out right now? It's okay.
I'm joking.
Yeah. It's like, it wasn't even the guy that had steak stuck there that was choking or that was freaking out.
It was the soup that was freaking out. Jesus, man.
Yeah, that was just definitely pretty silly.
You were telling me the other day that you had somebody come into the medical unit and they like had the balls to ask you out.
No, they didn't just like ask for my number. I'm cleaning out their infected poison oak wounds on their leg, like scrubbing out this pus, because I saw them on the previous fire and I was like, don't let these get infected. Skip to the next fire. Well, guess what happened? They're all infected. So I'm scrubbing out this pus and then he's like, so can I get your number? I'm like, are you kidding me?
Do you see yourself right now,
like,
dude?
Absolutely not.
Oh, man.
Yeah. But
shout out to that guy, though.
I know.
He's got some balls on him.
Yeah, definitely. It was pretty funny, though. So, yeah. Still laughing about it.
God, man.
Yeah.
So, now that we're on the topic, let's talk about trauma.
Yeah.
Let's talk about the real deal shit.
Yeah.
So,
absolutely.
Let's talk about stuff that you're going to commonly see, like common associated injuries associated with firefighting. So, what are you seeing out there? Like the trauma variety.
Yeah. What the biggest one for kind of trauma, like I just touched on before, you know, your small abrasions, cuts, scrapes, twisted ankles. Then we can get dislocated shoulders as well, especially if someone's prone to dislocated shoulders. Had a handful of those. Leading all the way up to your major traumas where, you know, the fire is going to shut down while this is being handled.
Yeah.
So a good thing to do would definitely be knowing your MER.
The MER?
I still call it the 9-line.
It's not the MER.
I know. Knowing your 9-line and going over scenarios of what if scenarios with your crew, engine, whoever you're working with. I do it with my partners as well, and I'm constantly doing it in my head.
Yeah.
It's good to have the what if. How are you going to handle this situation when it comes? Like, who's going to be in charge until the next person in charge gets on scene? Because you guys are on scene with the injury before we are.
Oh, yeah.
Most likely.
Oh, I guarantee you we are.
Yeah. Yeah, there's only been a couple times where I was like right there.
Well, it's not like someone gets hurt and poof, magically a friggin' medic is there, you know?
Yeah,
or
absolutely.
EMT,
so one big thing, let's say, you know, the dreaded tree strike that everyone's afraid of.
Ooh.
I mean, those are just awful.
Yeah.
And, you know, we're all familiar with the stories of what's been happening with those. So let's say
Have you
someone...
been on any of those?
Yeah.
I know we can't say.
Yeah.
We can't say what, but.
Yeah, and it's very traumatic.
Yeah.
But you have a job to do, and you know another thing that's important is make sure that I now don't have 2 patients because you got hurt yourself trying to help the other patient on scene.
Yeah.
But let's say there was a tree strike, then you know the patient's still alive but has a, you know, bleeding pretty bad out of the arm, like.
Okay, so like. Profuse bleeding.
Yeah, like so a branch probably hit them, but yeah, it's pretty bad. We'll call it an arterial bleed, so it's like there's pressure coming out of it, and those aren't good. So how are you going to handle it? Well, if you don't, especially if you don't have an EMT on scene that has gone through this scenario over and over and over, you know, start with the basics. Put direct pressure, stop the bleeding.
Yeah.
You know, help
the
us
red
out
shit's
there.
coming out of them. Make it stop.
Yeah, and when I say direct pressure, I mean your body weight on them.
No shit. Well, I've done the EMT thing.
And
so
this depends on your body size, though. So if it's like a 100-pound female and you're a 300-pound guy, like, you know, you're...
Back it off.
Yeah, back it off a little bit. But you want to put on a lot of pressure, and that's something that people don't realize. And that includes providers. I've been guilty of that, but just learning. Yeah. Like, you should almost be hurting them. But you're trying to stop the bleeding, especially if you believe that their life is in immediate danger. Like, they might die because of this bleed. Another thing, when a trauma does happen, it's really important to take a step back and look at the whole scene. It's really easy, providers included, to get tunnel vision.
Just
and
focus
you're focused
entirely
on
the patient.
Yeah, there's a good trip down an embankment or whatever, and someone, you know, breaks their leg, and their bone is sticking out, your eyes are obviously going to go to that. But do they have a head injury too?
Yeah.
And, you know, obviously
is their airway compromised?
Yeah, is their airway compromised? So always check their airway, you know, check for major bleeding, and then kind of go from there.
Yeah.
And if you don't know what to do, just ask too.
Yeah.
Yeah. So medical tends to get on scene pretty quick, especially the way that they have line medics all around. But, you know, we also might not be there if you guys are doing like saw work and it's not on an incident.
Yeah. So
it's good to go over these scenarios as well.
Oh yeah, you got to train how you fight, especially with medical, because I guarantee you when it actually happens in the field, it's not like working on a dummy or like a Tom dummy or anything like that. It's going to be a fucking, it's chaotic. It's going to be super chaotic.
Yeah,
so.
And every scene is going to be completely different. And another good scenario to do with that would be, you know, what if your soup or captain got injured?
Or the EMT.
Yeah. You know, like I was talking to you earlier, I'm always really nervous about getting injured out there, mainly because I feel like I'd be embarrassed to call it in. Like, can I get a medic for the medic, please?
I need help.
Yeah, it's like there is a medic on the scene. Well,
about that.
Yeah.
Yeah. Well, that shit happens though.
Oh, and it does.
Yeah.
Yeah, absolutely. But practicing with your captain or soup, if they were the one getting injured, if they weren't there, or if the EMT went, and it just, the big thing is knowing the operations about what to do. It goes back to knowing your MER 9-line.
The MER.
I can't.
And for you guys listening at home, that's page 118 of your IRPG.
Yeah.
Study that, know it.
Yeah, you know, you're probably not going to memorize it, but just know it, be familiar. So if you're the one that does call it into communications, because they're going to want that right away, you'll at least be familiar with it. Because the scene's going to be, you're going to be a little shaky, you're nerve-wracked and everything, like depending. So having that experience and going over it is really important. It's going to really help out.
So now that we're on the subject, like patient assessment, let's talk about how the mirror, it kind of acts as a patient assessment. It goes over mechanism of injury, what's wrong with the dude, how many people are involved, whatever. How valuable is that information for the arriving resources like you, the paramedic?
That is going to be valuable. That MER is what communications uses. Like they have, if there's an emergency on the line, they're pulling out a paper and they are going, that's following the 9-line MER. And they're writing down. So that's why it's important to go in order in that, know it. It's really going to help out communications. It's like extremely important with that. And also being familiar, like, oh, I don't know what a mechanism of action is. Or
mechanism of injury.
Injury, yeah, that's what. Yeah.
Mechanism of action.
I don't know. Don't even go there. Mechanism of injury. So let's say there was the tree strike. That would be, you'd say tree strike.
Yeah.
But if it's your first time looking at that, you might be like, what? I don't know what it is.
Yeah, what the fuck is this?
Yeah.
That's where you need to like take the diligence and ask your overhead and like, hey, let's run some practice scenarios with this.
Absolutely. And it's going to help out too for them because then their goal is to get transport. This person's injured. How are we going to get him off the hill? We need to get this person off.
You need to have contingencies too.
Yeah, contingencies, backup plans. You know, can we use an incident helicopter? Because, you know, a medical helicopter might not be available if one's not dedicated to the incident.
Yeah.
That's happened before where then I used the incident helicopter and just hopped on with the patient and, you know, it's just...
You're working on him in the helicopter?
Yeah, he was... It wasn't a huge trauma. It was the scenario was a lot better for me to do that and be back on the fire with an hour and a half rather than like 6 to 7 hours because of the construction.
How long ground transport was?
Yeah.
Dude, damn.
Yeah. So there's a lot of things. That's my job and the medical unit leader's job to kind of figure that out.
Yeah.
As well. And with that scenario, the other medic on the incident was gone transporting patients. So what are you going to do? Pull all ALS off? So
can't do that.
Yeah.
Yeah, you need standby. So.
Yeah.
But yeah, I think there's if you go through even this like the contact communications phase of your MIR, your medical incident report, there's a lot of high quality information that that the medics that are going to be arriving on scene get. Yeah. So, you know, hey, all right, even if you just don't know and your soup's down, you're just like your first year working a radio, just try and describe the situation as best you can. And this little line right here is going to make people sit down, shut the fuck up, and listen. Yeah. Once you say Division Alpha, just use an arbitrary division, right? Division Alpha, stand by for emergency traffic. Yeah. Boom. Everybody's listening. Yep. Yeah. And then, you know, just, hey, what do I have? Yeah. All right, my whoever, this person, don't ever use their names, of course, but hey, they were struck by a tree, having profuse bleeding or possible broken leg, or also state their level of consciousness if they're unconscious.
Yeah, let us know if
conscious.
they're awake or not.
Yeah.
If unfortunately, if you're going to start doing CPR, they let them know CPR in progress.
Super important.
It's a huge thing. You guys won't be ideally by yourself out there if it happens, but it's just really nice to be familiar with it as well. So if hopefully you never have to encounter it, but if it does, you can hopefully kind of take a step back and remember what you practiced as well. And
location too.
Yeah, location.
That's definitely important.
Know your coordinates.
Know how to get them.
Yeah, they're going to want the exact coordinates of the injury, what the injury, what happened, what possible injuries you think they have. Like the level of consciousness is really important. And then if you know them, let's say it is your captain and he has a cardiac history or something. Just
That's super important
when
too.
the medical gets on scene, maybe have that kind of just jotted down and hand them the paper of the name. If they're able to get allergies and everything, because anything that we can do to get that patient off scene as quick as possible is going to help.
Yeah.
Now, with these kind of scenes, when I am transporting the patient out, I do have a long time with them, most likely, unless I'm just handing them off. So I am able to get, the history is not as important unless you do think it is pertinent to what's going on. If it is like a man down because of medical, of course, we want to know there's a cardiac history there. So having that knowledge and just kind of jotting it down can help out. And also it can kind of help delegating those if people on scene are having a hard time with it or don't know what to do. It's like, hey, why don't you write this down for me? Or, hey, can you go do this?
It's definitely important to have a scribe.
Yeah, and delegating can really help. I know that's having major incidences on these fires has always been all of a sudden I'm just surrounded by captains that are all ready to scribe. I'm this is so much better than just working 911. Yeah, so then
you have help.
Yeah, so there's definitely a lot of different things you can do. And then one really good thing to go over is how to transport a patient out. So, kind of like assisting with a litter carry, or how would you get someone up a hill, down a hill? Let's say REMS isn't on this incident.
Yeah.
It's a smaller one. Do you guys know how to do that?
Packaging a patient's kind of hard. I don't think people really understand how difficult it is running especially a hard rigid backboard.
Mm-hmm. And you got to watch your feet and everything as well, because then all of a sudden we're going to have 2 patients, and we don't want that. Yeah. So just knowing your surroundings, absolutely.
Yeah, that's the worst thing is now you have 2 patients and one critical and one might be ambulatory. It's like
and if you have enough people, if we are, let's see, carrying the patient out, or let's see, you're carrying them out to me because that was just a better thing. Mm-hmm. Then if you have one person that can just stand back behind everyone and just overlooking the whole scene, because everyone's really focused on getting this patient out or whatever. So kind of just overseeing.
It even happens in training scenarios. Everybody's focus is primarily right there on whatever trauma or medical you're running.
Yeah. So. I know. In an ideal situation, which happens a lot, I'm working with another medic, or there's another medic on scene, maybe with the REMS team, and just also delegating that because, as the medic on scene, that patient is my priority. Yeah. That is who I am in charge of. But on fires, I'm not in charge really of the whole scene because there's a fire going on. Yeah. So that's what's different. But just delegating those tasks as well and being able to step back is going to help you, I think, be more successful in what could be a very traumatic incident. Yeah, you definitely got to get them away from further danger as well. So if they're working on a tree and some branch hits them or something like that, and they're down in an ash pit, don't work on them right there. Yeah. Pull them the fuck away from danger. Yeah, because for all the EMTs, BSI, scene safety, well, none of our scenes are ever safe on these incidences. Yeah, it's inherently dangerous. So, just kind of what are you going to do? It's inherently dangerous. It's kind of just the consequence of what the fuck's going on a wildfire. Yeah, look up, look down, look all around applies to every aspect out there. Oh yeah. And even when I think that's another thing too for whoever's running the scene, whoever's the within an incident commander, you got to have all the same operational things going, just like you're running a fire. You got to have your absolutely LCES in place. You got to have your comms. You got to have everything. Yeah. Scene safety is going to be number one priority. Yeah, because unless I'm first on scene, I'm not going to be the IC for this incident because I need to focus on the patient. Yeah. Then I'll let them know transport decisions and whatnot, and someone else is communicating with communications. Yeah, they're basically passing messages back and forth to communications. Mm-hmm. And I've been on some incidences like that, and the people I've been dealing with have been just awesome. Yeah, as captains and soups because they have trained up on it and practice scenarios and just kind of or didn't know what to do, that they can assist me, and then I also can assist them by communicating with them what needs to happen.
Well, you can. I mean, even the layperson, like your first, second year. I mean, you need to know this shit.
Be familiar with it.
Yeah,
and go over the scenarios. If you have an EMT on your crew, ask to know how to package a patient.
Shit, take that that jump bag off the truck. Go through it. Know where your oxygen kit is. Know where your airway kit is. Know where your trauma bag is, and always.
Yeah, the trauma is big too. Even because you might break into that for like not a big deal, but they need to get gauze. Just know where your stuff is.
Yeah.
That has, I've been caught with my pants down when I like kind of first started, where I like got on a new rig.
Are we not using phrasing anymore?
I mean, you can. I was kind of hoping you jumped in there. I'm a little disappointed. Not mad, just disappointed.
Whatever.
Anyway, so my pants are down.
Okay. Pants are down.
No, and jumping on a different ambulance, and it's like, wait, I don't know. I didn't go through this bag. Like, so I just have to, look for it more rather than like, oh, it's in this pocket right here. There's a glucometer. Perfect.
Yeah. So. But then again, if you're not familiar with it.
Yeah, it's kind of like, crap, where is it?
You're just wasting, well, you're not wasting time, but you're reducing the amount of time. You have that golden hour to get somebody to definitive care. Yeah.
No, that is what would be the ideal, get you into surgery if it needs surgery, if it's that traumatic of an incident, with under an hour. That's the goal. And they call that the golden hour, as you said. Mm-hmm. So that would have.
But that never happens in our line of work.
No.
We're in the middle of fucking nowhere, and
Yeah, I've moved quick before. Time definitely stands still when it is kind of an emergent situation, though, that's for sure. And then you think that you're working on someone for an hour, and they're like, no, we're on scene for 8 minutes. It's like, okay.
Jesus.
Yeah.
Well, hey, that's a platinum 10, though.
Yeah, right.
That's good stuff, as long as you're getting them transported.
That doesn't usually happen. Well, it depends.
Well, yeah.
Because when I'm on scene 2, if the patient can walk, it's like, okay, hop in, we'll deal with everything en route, because it's usually takes a couple hours to get to the hospital.
Yeah, go through all your patient assessment like in route.
Yeah,
it's probably best scenario.
As we like to say, let's get in my office. I want the patient into my office so I can work properly.
Just like chew cans of burrito wrappers everywhere.
Because there is a fire going on and people need to resume operations.
Oh yeah,
that's the other thing. If it is an emergent traffic,
well, the fire doesn't stop. It's gonna do what it's gonna do.
Yeah,
so
it could take a little break, but it doesn't.
Like, the fire's like, oh, I'm late tired.
Yeah, yeah, right. We said emergent traffic fire.
So let's get into like some of the trauma aspects, like bleeds. Like, how does the layperson take care of like a major bleed besides direct pressure?
If you're familiar with a tourniquet, if someone on your crew has a tourniquet, take it out, practice. You can cause damage with a tourniquet. A lot of times bleeds can be stopped with just that direct pressure. You don't want them to lose a limb. If you do feel that a tourniquet would be the best course of action because the bleed is not stopping, you get familiar with the tourniquet you have. There are some different types out there. Mm-hmm. And you just kind of want to turn it or tighten it just until the bleeding stops. You don't want to crank it down till, the whole arm is blue.
Yeah.
Unless that's the only way to stop the bleeding, but ideally, just until the bleeding stops. It might not be as much pressure as you think it is, because it might just pinch off that artery just right. But familiarity with your tools is very important. And then if you do put a tourniquet on, write down the time you put it on. Just put it on tape and tape it onto the patient. That really helps out as well. So they know, wow, this tourniquet's been on so long.
Yeah. But
ideally that they won't lose function on, in their limb.
Well, hopefully if you need to put a tourniquet on, shit's real bad.
Yeah.
Real bad.
Yeah.
So.
Yeah, definitely just depends. I mean, like everyone knows, tourniquets have definitely saved lives, though.
Oh, yeah.
Yeah.
There's a lot of data, unfortunately, coming out of Afghanistan and Iraq, and they're saying now that you can put a tourniquet on for like up to like 6 hours or something like that without loss of limb. Uh-huh. But that being said, though, if they have like that severe of an injury to where you need to put a tourniquet on.
Yeah.
I mean, if you think it needs a tourniquet, don't ever hesitate to put one on.
Yeah, absolutely. Because let's say, someone got a freak injury on the wrist or chainsaw to the wrist and they're, bleeding out right there. Yeah, pop that tourniquet right above the wound on their forearm until the bleeding stops. Because or just do direct pressure and hold it above their head. But do the tourniquet if that doesn't work. So for my EMTs out there, you probably remember those scenarios, like what the steps to do, direct pressure. If that doesn't work, consider a tourniquet.
Yeah.
And that's very true.
Well, tourniquets, they can be life-saving, but, they come with their consequences.
Yeah, absolutely.
I definitely, Me personally, I'm going to treat as aggressively as possible within reason.
Absolutely. And then, because you don't want to put a tourniquet on and then take it off as well.
Yeah.
Usually, especially without like a medical professional, or the only way I would do that is if medical control, like my doctor told me to.
Yeah.
But yeah, we'll get, then get them into the hospital as soon as they can, and then the doctor will deal with it. Because most likely they're not going to lose that limb, and depending on the injury, of course, because of that tourniquet, if you just do it till the bleeding stops.
Yeah.
So.
Well, then, that thing's only going to be on there for a few hours before they get to definitive care, at least.
Absolutely.
Yeah. So let's talk about crush injuries. Yeah. Tree falls on your leg. Ow, fuck. My leg is crushed and pinned underneath a tree. Yeah.
So that's where it gets a little more
super complicated.
As well for like treatment. We take into certain considerations, like how long has this limb been crushed for? Have you been able to get the tree off them yet? Mm-hmm. If it's been more than 45 minutes, then as a medic, then we're going to come into once you release that tree or pull it off.
Bicarb them?
Well,
not bicarb.
It is bicarb. Protocols are always changing because it's going to be very acidotic, mm-hmm. and that can cause them to go into shock by all that acidotic blood running back into the system. So crush injuries are no fun. They're obviously extremely painful because all your nerves are being crushed, and it's like a lifelong thing.
Yeah.
But just handle it as you kind of would any basic care. Is there obvious bleeding, or is it a closed crush injury? Stabilize the limb if that's what it is. And, that would definitely be like an emergent traffic situation, of course.
That's some no shit stuff. But you can get a crushing injury just by, like, say you're driving an UTV. Mm-hmm. You weren't wearing your seatbelt, you got ejected, thing rolled over on top of you. That's still a crush injury.
Oh, absolutely. Yeah. So it just depends. Can you get the tree off right away? Let's say you do, and then treat it as kind of you would any other injury. Is the leg mangled? Can you stabilize it, or just kind of package up the patient so the leg is like protected until we can get there and give them pain meds?
Yeah, pain management.
Yeah.
Here's some ketamine.
Yeah.
Night.
Yeah, there you go. And that's definitely a surgical situation.
Yeah.
100%. There's not a whole lot to do, but just keeping the patient as comfortable as possible, stabilizing the injured area to the best that you can, and go from there, and then focusing on also how are we going to get this patient out of there? What can I do? Do we need an LZ?
Huge logistical effort.
Yeah. So should some guys start making an LZ over here? Mm-hmm. So, yeah.
So I don't know what your protocols are, but do you leave the thing that crushed whatever? Do you leave it on them until like the very last second when you have like flight or care flight or whatever on scene?
No, I mean
immediate removal. Yeah,
you want it off them kind of as quick as possible, but you also, like, if it is the leg, some things you'd have to consider is a femoral artery crush. Does it look like there is like bleeding? Should I have a tourniquet ready? But you want that object off of them as soon as possible, because the longer they're crushed, the more problems are going to potentially come up. They might lose that limb then. Yeah. So
that's another thing too with our protocols.
Wait, so is that your protocol is to leave a?
No, we don't. We immediately remove it. But once, before we remove the object, TQ, tourniquet, and take all that bad crush shit and like keep it in that compartment, because it's going to swell. It's going to go rushing back into the body. Granted, there's no arterial compromise. Or venous compromise.
Yeah, and it just, that really depends on how long they've been crushed for it. But have your tourniquet ready. Put it on. You don't have to tighten it.
Yeah, because whatever is on them is acting as a tourniquet.
Yeah, and having, if you guys have like a blood pressure and stethoscope, taking their blood pressure with those kind of injuries.
It's going to be huge.
Because, if, then you can say like, oh, their blood pressure is dropping. Well, then they probably have an internal bleed.
Yeah, they're going into shock.
Yeah, or their adrenaline's kind of wearing down. There's all these different possibilities, but there's nothing wrong with like starting to do vitals for me.
As long as you know how to do them.
Yeah, absolutely. Because especially in something like that, it's good to monitor. Like, oh wow, their blood pressure has been pretty stable for the past half an hour, so this is good. They're looking good.
That's good.
Yeah.
So what about breaks and fractures? Rolling rock hits you in the ribs. So, flail chest. That's fucked up. Let's not go there. Let's broken arm from a rolling rock.
Yeah, that's how deformed is an arm, just kind of stabilize it, make the patient comfortable. Once the, sorry, just burp.
That was cute.
Once the medic gets on scene, they'll definitely, start with the pain management and transport. Yeah. And it always depends on the break. If is it a hairline fracture, just kind of swelling, we're not going to know. We don't. Yeah. It's going to be obviously deformed and look like a break, absolutely, but still can't say they broke their arm because we're not X-ray.
You want to say it, don't you?
What?
Decap BTLS.
Oh, yeah, that all came screaming back. Yeah.
Oh, you're getting PTSD from medic class.
No. Yeah. When you do take EMT classes, they just go through these certain scenarios. And so decap BTLS is what you got to go through in your head.
I'm not going through the entire list of what that
You're
stands
not?
for. No, go ahead, fire it away.
No. So what's
away.
the deformities, contusions, abrasions, penetrating wounds, penetration.
Phrasing again.
Yeah. Was it burns?
Yep.
Oh, what's T?
What was T?
Oh, I was on a roll too.
Yeah, you were on a roll.
I just stopped because I distracted myself because I'm a child.
How's that ADHD treating you?
Oh, it's so good. What?
What? Fish. I like fish. What is T?
Oh my gosh, this is embarrassing.
Yeah, tenderness.
Tenderness.
Yes.
Thank
tenderness.
you.
Yeah.
Lacerations and swelling.
Yeah. that was rough.
Yeah. So
having flashbacks.
I just want to apologize to all the listeners for that. Yeah.
So now, what do we do about, like, say they got a compound fracture?
Mm-hmm. Like open
bone
compound, sticking out,
which is wildly distracting.
Yeah, it is. Been on quite a few with that.
Yeah, pay attention, guys, because if you have, like, look at the whole big picture, because if you have, like, a compound fracture on somebody, you're going to be like, holy fuck, this guy's going to die, but that may not be the big problem.
Yeah.
Yeah.
There's been instances where it's been like a compound fracture in the arm, which is when the bone's sticking out. And then, your eyes immediately go to that, but it's like, oh crap, but this guy's unconscious, and that's not from the compound fracture. So that can be addressed later. Yeah. So that can be addressed later. So that's the whole part I've said before about taking a step back and looking at the whole scene. And then if your patient's conscious, like, talk to them, ask them, like, what does anything else hurt? What's going on? Like,
are you allergic to something?
Yeah, right. Yeah. And like, I can also the medic can take care of those questions as well. But and in talking to your patient also to keep them calm. I'm assuming, or probably your friend, your crewman, like, and this just comes with practice of kind of sounding robotic if you have the EMTs going through all this stuff, and that's fine. But remember, this is a person too, and they're just having an injury, and it's like really good to try to keep them calm.
They're going to be freaking the fuck out too.
Yeah.
So it's like, the more calm you approach the situation with, I think the calmer the patient's going to be.
Yeah. Like, joke with them a little bit, depending on how well you know them.
Yeah.
And just, that's really important as well.
Yeah, that's super important. All right. What about one of my personal favorites? Allergies.
Allergies.
Yeah.
Oak. The worst.
So let's talk about, like, food allergies. Say, because you don't know what the fuck you're going to get in your food lunch, right? Your fire lunch, rather.
Yeah. Well, ideally, know if you're allergic to something. Yeah.
Yeah.
Letting them, I think you can let the incident know if you have a peanut allergy, right? Like, or
you should be able to. Yeah.
Yeah. I think they're pretty careful with, like, peanuts and whatnot. And people that have those allergies, they know about them. They grew up with them. They have their EpiPens and everything. But sometimes things are out of their control. Someone else has it.
Yeah.
So anything with that, and in that case, if you think someone's having a food allergy, you have your Benadryl, you have your antihistamines, and call a higher medical over or whatever, or bring them to the camp to get evaluated.
Well, I think this is also an important thing to, like, actually know your crew. Like, yeah, if you know they have an allergy, know where the fuck their epi's at.
Yeah, it is.
If
that
they
is
have
really
it that
important.
bad,
Yeah, if you do have a bad allergy, if you are, really allergic to bees, make sure that their crew knows, because then they'll know you have an EpiPen, and if you do get stung, or just communication is super important.
It is super important. Yeah. Like, know your guys. Know your folks.
Yeah.
Yeah.
And then my favorite allergy, poison oak. I know.
I've seen some horrible poison oak before. I don't get it. I'm one of those lucky people.
Okay, that's
get it.
No. So I always said yes. Because I would always say that too. I'm not allergic yet. And I actually got it paddleboarding on Whiskey Lake, like, a week before the car fire started.
Whiskey Town.
Yeah.
Oh, you probably don't want to say that out loud. A week before the car fire started.
It was a week before. We know how that fire started.
Yeah.
But I know there's definitely no more oak up there.
Nope.
But yeah, when I got the oak, it was like in a weird pattern because it was on the paddleboard, I guess. And so I don't know if anyone's been on the paddleboard. It has kind of like that grid on it. So I had these like perfectly spaced out like blister lines on my leg. I was like, what is that? It's so itchy. I was like, it must be bed bugs. I was staying at my friend's house. So we like went through her house. She had a very clean house. So I was like, what is this? And then it started spreading everywhere. I was talking to my boss. He's like, I don't know. And then finally my other boss was like, it's poison oak. I'm like, no. Then we're like, no, it's not oak. And then it's like, yeah, it is. It's for someone that's been working and treating people for so long. That was not the highest point in my medical career. It definitely was oak. I was just in such denial about it.
You did, like, you knew damn well what it was. But
yeah.
I
took so many rounds of steroids. Like, it was bad. It was just, I looked gross. My arm. Man.
Was it all swollen? Oh, you sent me a picture.
I sent you a picture with all just the forearm and everything. It was all up and down my leg. I was like, don't look at me.
Like you look like a fucking burn victim.
I know. But then I also discovered how awesome Xanfil is. So
there you go.
Yeah.
So as far as poison oak, aside from your severe cases, like, especially you gentlemen out there, like, take a little extra precaution about what you're doing when you go to take a leak.
Yeah.
You're catching my drift.
Yeah, behind the knees, it'll get there too. And also on the genitals is really painful. And at that point, you probably need a steroid shot. So if there is like a medical unit in camp with like a nurse or PA, they'll administer that or we'll send you in to get that taken care of. And then with oak too, it's kind of educating yourself on how you're getting oak, keeping up with the Technu. And, yeah, because the Technu acts as a dish soap. You know, you think the poison oak
strips the oil.
It's getting the oil on you, and the oil's getting on anything. If it gets on your pants, it's gonna get on your sleeping bag, and then you're gonna keep touching it. And even if you get treated with a steroid shot, if you climb back in your sleeping bag, you're gonna get oak all over again.
Yeah.
So
it's not like that shit goes away. Ursha oil is actually
changing out your Nomex when you can. Taking a break on the line if you know you encountered it, and just with a water bottle and Technu, just like wash your hands. Now they have like the Technu wipes, which is just a Technu on a wipe, but that's just a little more convenient to take with you, or the small packets. And then do what you can, and then shower when you can. I know there's all. It does seem like people are showering more, which is good, like especially because a crud gets so bad, and then when these guys aren't showering, and girls, we're all disgusting. Let's be real.
Yeah.
You know, and I'm definitely get guilty of that too. You get back, you just want to eat and go to bed. But the showering has really helped to like lower it, especially if you do get oak. Just shower as fast as you can.
Yeah.
Now, you know, a lot of these guys though are out on these 14-day spike camps, so
yeah, good luck getting showered.
Yeah, good luck to you guys. I appreciate you
and
all.
And of course, if they want to go like jump in the river or something like that and kind of clean off, of course, what's around the freaking riverbanks?
You're right.
Fucking poison.
Yes, so much oak.
Ugh. Well, there's only two people in this world, two types of people in this world when it comes to poison oak. People that have had poison oak and people that will get poison oak. So I've been immune for a while now, but I'm sure my day's coming.
Yeah.
Yeah.
I don't know. The whole so bad. I'm still just like so bad.
Are you shaming yourself right now because you couldn't recognize the symptoms of poison oak?
I was in severe denial because I would always be like, well, I don't get oak, so
it's not poison oak.
Yeah, I don't know how you feel, so good luck. And then I just came out of vengeance. That's not karma. I don't know what is.
Jesus, man.
I got the oak, man.
I got the oak.
I got the oak.
Yeah. I don't know, man. It's definitely some good topics. Do you want to go into maybe like what to expect, like the aftermath, like that secondary trauma though? Because when you see some trauma,
a little bit of mental health.
Yeah, dude, because it's seriously, peds especially, if you ever see ped trauma, it'll fuck you up. I don't care how tough you are.
Yeah, absolutely. That's kind of like a good trigger word right now, the whole PTSD movement, or like, you know, getting that out there that it's okay to have it. A lot more people kind of have it that they know about. I've personally suffered from it, from an incident that happened while working that was extremely traumatic, from the being intubated too. That caused a little bit. That was like the start of, and then you know, we've had friends die that can cause it as well, but we don't want to admit to feeling down or needing help. And I personally got in a really bad state as well, like just being angry and just not in the right head place and like lack of motivation. And it wasn't like I was depressed. I'd go through like bits of depression, but you know, I wasn't me. And finally I reached out to a PTSD clinic and I got help, and it changed my life. And I'm proud to admit it, that I got help. I felt like me again. And I don't feel any shame in that. And that's really important. So if you do encounter a traumatic scene, whether it's...
Well, it could even be cumulative too. Like if you're like, especially someone in your position where you're dealing with this shit like all the time.
Yeah.
Like that repetitive trauma.
And, all my stuff that kind of happened was actually mostly like not work related, but that's also was like, oh, I'm fine. And it did also kind of reflect in my work a little bit. And I could tell like I had a coworker, like, what's going on? Yeah. You're kind of angry, and I'm not an angry person at all.
Are you though?
I mean, I'm Italian Irish, so I have that
the sass.
The
you have the sass. Yeah.
Yeah. But I'm really happy I did get help. And when you do deal with these traumatic incidents, if you are unfortunate, and I don't want anyone to go through this, but if something bad happens to someone you're working with, or you're there on the scene, it is important to get help. I was sent to these critical stress debriefings for some stuff, but I'm not receptive to that.
No one's going to be, because it's happened so well. It depends.
People are, though.
People are.
But I had to find effective. The right thing for me that helped me. And there's also for PTSD, there's they now are doing ketamine stuff.
Ketamine clinics.
Yeah, EMDR, which is they track your eye movement, has had a huge success rate. So there is a lot of different ways to get it. And that allowed me to be more receptive to getting help. Yeah. And also what's hard with us out there is, after something bad happened, someone would talk to me about it. It's like, I'm not talking to you. You have no idea. You went to, and this is not really fair because I don't know their life. But my thought process was, you went to school to become a therapist. What have you seen? What do you know? I'm not talking to you. I only want to talk to someone that
has lived your life, that walked a mile in your shoes.
Yeah, absolutely. And, with the stuff I've gone through and the treatment I've gotten, it has made me really want to be there for people, because it's I do get it, and a lot more people do get it, and you got to find what works for you to get that help. But there is some methods that people are very receptive to, and it's pretty great.
You got to take care of yourself.
Absolutely. Your mental health is just the most important. Yeah. And we're all out there. Sometimes people kind of snap out there. It's hard when you're out there for 21 days kind of a thing. So
especially if you've just seen some shit and you're just staying on incident.
Yeah. If it's something really bad, you usually, I think, leave. But also watching your crewmen, if you're noticing a change, if something happened in their life, sometimes stuff happens at home when we're on these incidences. It's okay, I'll work through it. Just kind of being there for each other, checking in on each other is really important. And I know for me, I can be stubborn if people are oh, how are you doing from this? It's I'm not talking to you about that, but just hey, how have you been? Yeah. What's going on? Yeah. What's going on? You holding up? Especially in for soups and captains and stuff, in that leadership role. I know for me, that always was nice, because it was thank you. Yeah. Yeah. So, because we all just have to be there for each other.
That's what it boils down to, is just know each other.
Yeah, and not
take part in that brotherhood and sisterhood.
Yeah, and not feeling any shame if you're not feeling right, especially after something happens in your life. Oh yeah. Talk to someone, you can get some help and find out what help works for you. Because the earlier that you interact with this, trauma in your head or what's going on, the better you're going to be, and you can get back to normal. You can resume normal activity. So,
powerful advice.
Yeah.
Take care of your headspace, man. We always strive to take care of our physical bodies, in our nutrition. Yeah. Even though we're fed a bunch of fucking trash on the fire line.
Our insides is all black tar out there.
It's just coffee, Copenhagen, and
we're all just walking piles of garbage.
Riddled with cancer.
Yeah.
But yeah, most importantly, you can't be healthy as a person unless you're healthy in your head.
Yeah. So taking care of yourself. Absolutely.
Definitely good words of advice.
Good.
All right. Well, we covered just about everything that a fire line medic goes through on an incident.
Yeah.
Good information.
I did my best. There's so much information out there, and if you ever see me on the fire, say hi for sure.
Oh, for sure.
Yeah, and another thing is I love to educate. Running scenarios with people. In most medical people out there will. If you're out there with a line medic, you have the time. You don't know what you're doing. You might be staging.
Yeah.
Ask questions. Run scenarios with them.
Oh yeah.
Like get everyone involved. I love working with them, like staging with like a engine and stuff. Like what would we do? Let's do this. It's great.
Well, shit's important because when the real thing happens, you need to like get on it as fast as possible. Because time is probably one of your most precious resources.
Absolutely.
So
yeah, and I really enjoy my job and what I do. That's why I've been doing it for so long. And like I said, I love talking with people about it. If they have any questions.
Really like the people hitting you up in fire camp asking you for your number when they're covered in poison oak.
No, he was covered in pus.
Or, sorry, pus, oak pus.
And if you're listening to this, I'm sorry.
I gotta give a shout out to that dude, man.
No, I know for sure.
Yeah, that's brave, bold move.
Yeah,
bold move. Well, cool. I think that's a tie-in point.
Awesome.
Thanks for coming on the show. And where can we find you on the socials?
Oh yeah, Raponi on
Raponi.
Yeah, on Instagram. That's kind of my only social that I have.
Okay.
If you guys have any questions, feel free to write me. I'm happy to help.
Don't slide into her DMs and be a
don't.
douchebag.
Yeah, I'm too socially awkward for that.
Yeah, if you guys slide into her DMs and be like, "Hey, what's your number?" We will put you on blast.
Oh, 100%.
Yeah. So.
But no, I'm not going to put you on blast if you do have any questions, especially about any kind of mental health or anything. So
yeah, keep it professional.
Okay.
All right, dude. Well, thanks for coming on the show.
Yeah, thanks for having me. This was fun.
Yeah. Right on, guys. Well, thanks for listening to another episode of Anchor Point. We'll see you on the next one.
Bye.
Bye. Hell yeah. That was a good episode, Michelle. Thank you for coming by, dropping some knowledge bombs on us with emergency medicine. Definitely appreciate it. We covered so many topics. Got everything from owies, boo-boos, and blisters to some serious shit like trauma and anaphylaxis, crush injuries, breaks, fractures. Shit, we even covered poison oak. Anyways, yeah, guys, definitely know that MIR 9 line. It's called the MIR now, so let's get some terminology right. The Medical Incident Report. Well, guys, I hope you enjoyed the show. Definitely keep tuned in. Definitely swing by our iTunes, drop us a rating. Definitely swing by our Instagram and our Facebook. Twitter, I'm really hardly ever on it, but whatever. If you guys want to follow us on Twitter, feel free. Anyways, guys, thanks for listening. Catch us on the next episode of The Anchor Point. Later.